Good evening, everyone, and thank you for joining us for tonight's Woo You event. Tonight, we have Dr. Julie DeKinder, and she will be talking on contact lens fitting for myopia management. I'll be your host tonight. My name is Dr. Arielle Sorenzi, and I'm super excited to introduce our speaker, Dr. Julie DeKinder. She was my residency coordinator at UMSL, and she is absolutely amazing, an amazing mentor, and she just knows everything about all contact lens stuff, but especially myopia management. So she is the clinical professor at University of Missouri St. Louis College of Optometry, where she's also the associate dean of academic programs and director of residency programs. She's a fellow of the American Academy of Optometry and a diplomate in cornea contact lens and refractive technologies. She's a fellow of the Scleral Lens Education Society, a member of the AOA and the Missouri Optometric Association. And she is currently serving as the immediate past chair for the Association of Optometric Contact Lens Educators and vice chair of the Accreditation Council on Optometric Education. She serves on committees for the AAO, ACOE, and ASCO. And by the way, she's also a mom, and I don't know how you do it all. So really excited to have you. Thank you for joining us tonight.
Thanks for having me. I'm thrilled to be here.
So have no financial disclosures to disclose. And I will go ahead and have you take it away from here.
All right. Thank you, Dr. Sorenzi, and a huge thank you to Dr. Wu as well. I was lucky enough to be residency coordinator for both Dr. Sorenzi and Dr. Wu, and I'm always proud of all of my past residents, and I'm especially proud of both of them, and just thrilled and humbled to be here tonight, getting to share my love of contact lens fitting with all of you. So this is going to be a quick snippet, right? A lot of times when I lecture on myopia management, it's longer lectures, couple-hour lectures, really getting into the research and the theory behind what we know, what we don't know, and then lots of different options for treatment. Tonight, we're going to focus on contact lens fitting. So I may briefly mention a couple other options, but really the focus is going to be contact lens fitting for myopia management. And I'm happy to answer questions after the presentation as well. I was lucky enough to get involved with myopia management way back in the SMART study, which was very early in my career. And I'll be quite honest with you, I probably didn't really know what I was doing very much back then. But what it did was it kind of made me realize a couple things. It made me realize, hey, I actually really enjoy seeing kids and fitting them in contact lenses. And you can really change lives by getting into this area. And so through the years, we've really developed, at the college, we really developed our myopia management clinic. And there's really not a day that goes by in clinic that I do not see one or multiple children that are either currently in some sort of contact lens for myopia management or are there to be fit in lenses. So it's constantly happening. We're growing in numbers. We love doing it. And I hope that I can share some of my knowledge with you tonight. So just as an overview, we're going to talk about just a few things I always like to talk about in my lectures when we talk about fitting children. We're going to go a little bit over safety, and then we'll talk about the two main contact lens options when we're talking for myopia management. I have no financial thing to disclose and nothing to gain by saying this, but I will say if you have never signed up to receive these weekly emails from Review of Myopia Management. This is a screenshot from their inaugural issue, which was in 2019. This comes to my email every single week, and myopia management is such a hot topic, and there's so much amazing research that is coming out all the time. Every single time I give a lecture on this, and I feel like I lecture several times a year on myopia management, I have to dig into the research again because there's so much new research that's constantly coming out that it's very, very hard to stay up with it. But I don't want to mislead anybody by what I say, so I want to make sure I know what's going on in all the research. And this is a great way to just get snippets of what's going on and then decide which articles you want to go dig in deeper to. So you can sign up for this. Like I said, it's an easy email. I think it's fantastic. And I know there's lots of other opportunities out there like this, but this is one that I really find helpful. So the ACHIEVE study was done by Jeff Walleen a long time ago. And I always like to talk about this because if you're talking about fitting kids in contact lenses, I think it's important to know a couple things. And one of them is you're impacting the child's life more than just improving probably their life as in respect to saving them from some myopic diseases and high prescriptions. That's going to make their quality of life better. You're also helping them with their physical appearance. You're helping their ability to play sports, and honestly, their acceptance among friends, which is really crazy that by just putting contact lenses on a child, you can significantly improve these aspects of how they feel. This is a picture of my daughter. You'll see my children throughout this. I always start these out by saying, hey, guess what? Practice what you preach. I have two kids. My daughter has been in both soft multifocals and orthokeratology for myopia management. My niece wears orthokeratology. My nephew's in soft multifocals. So every family member that I see of those kids are in some sort of myopia management because I feel very strongly and passionately about it. So my daughter's a swimmer and she plays water polo, and right now she wears orthokeratology. And I will tell you that it must work because her prescription is significantly lower than both mine and my husband's. The other thing that I think maybe would shy people away from initially considering some sort of contact lens modality for myopia management is the time commitment, right? Oh, these kids, it's going to take me longer to do everything. And the CLIP study, also also from Jeff Walleen et al., said, no, it's really not, right? You can very confidently fit children as young as 8 in soft GP or orthokeratology lenses. And technically, I mean, truthfully, your chair time may be only about 15 minutes longer. And I find that's even less. I find these kids are actually pretty fantastic at putting the lenses in and out. And really, that's what it was. It was the actual time it took for lens and application and removal training that added that extra chair time into the process. And it actually only took 15 minutes longer for the little bit younger skewed than the 13 to 18-year-old. So you really, it's not going to take a lot more of your time, and the impact you're going to be able to have on their vision in their life is significant enough that I'm going to say that it's worth it. And if you think from the study that 8 should be the age that you start with, I'm going to challenge you to think a little bit outside that. I have children as young as 6. I think the youngest I fit in him was 5, a brand new 5-year-old. But in this last year, I fit a couple that were 6 years old in lenses for myopia management because honestly they needed it. I talked to the parents about it. We educated them on all of their options, and the parents had both the interest, the motivation, and the kid was willing. And those children, they just do fantastic in these lenses. They really, really do. So don't let that shy you away from trying to fit them. So some of those important factors you do want to look at when you're talking to the kids and the parents is both the interest and the motivation. There's been a few times in my career where the parent has really wanted the contact lenses for the kid, and the child had no motivation. And when we think about orthokeratology lenses especially, they can be a little uncomfortable, at least initially. And I know that when they close their eyes, they're more comfortable, but that's not always the case. A lot of these kids can still fill those in there. And I've had situations where parents have said, I really want to do this, but I find my kids going to bed and hiding from me so I don't have to put them in. That's probably not a kid that's truly motivated, and it's the parents that are motivated in that case. And that would warrant a conversation about other options, other modalities to treat their myopia management, because if they're not wearing the ortho-K lenses, then they're not doing the work we need them to do. So you need to keep that in mind. I think it's always good to assess maturity. I do have parents that help the kids put the lenses in and take them out. And I'm okay with that personally in my practice. As long as the parent's willing to do it, and as long as they're willing to allow me to continue to work with the child when I do see them, to get them to the point where they can do it themselves. In the initial phases, I'm okay with the parents helping in that. I think when you think about sports, these are great kids to put in contact lenses. And they're the ones that are going to benefit, really a lot from the ability to have a lower myopic prescription later in life. I understand that some sports have higher critical visual needs, and you may be concerned when you put one of those type of children in a soft multifocal, because sometimes the soft multifocals don't give us the quality of vision that we expect from, like, say, a spherical soft lens, or if you got them in a well-fit ortho-K lens. And what I've done in those type of situations where really the parents and the child wanted to go with the soft multifocal, and I felt like, oh, I wish I could get their vision just a little bit better for these very high caliber sports they're doing. And what I actually do in those situations is I talk to the parents about, while they're doing a very specific sporting event. So if they are like a softball pitcher or a baseball pitcher, why don't you buy a small selection of daily disposable spherical soft contact lenses that give you great distance vision while you're doing those activities? So if you're a baseball pitcher, you need to have very crisp, sharp vision, and you might not be getting that with your soft multifocal. It might be a little softer, vision. And so then they can use that when they're playing the sports, but then they can wear the soft multifocal for the myopia management component in the rest of their life, and you're still getting the treatment you want out of it. So that's kind of one of those ways I address that, especially if that's somebody that isn't interested in orthokeratology. Safety concerns. You know what? I fit a lot of orthokeratology, and I should knock on wood because it's going to happen to me now. But I really, there's only one time that I can even remember in my career that I had an infiltrative keratitis that occurred an ulcer that occurred to a patient. It was very, very early on in my career. So here's a couple reviews that show it is safe. We have the evidence through these reviews that show it's safe. And then more recently, related to soft contact lenses, we have something that also says that the incident of these corneal infiltrative events is very low in children. So you can feel confident that it's a safe modality, that you can put these young children in these contact lenses. I'm the immediate past chair of the AOCLE, which is the Contact Lens Educators Association, and we have these wonderful resources on our websites. They're free. You can download them. I give these to every new patient that walks in the door. We have one for corneal reshaping. Here's the link. We have one for soft contact lenses that you can use for the multifocal, so you can print these off and share those with your patients. It's just a reminder about healthy habits, because I think that healthy habits are important, especially when we talk about any safety concerns we might have. Educate well, discuss what those concerns might be with them on the front end, so they know when something's not going right, and they can come back in and see you, and you can address it very quickly. But I love to give these out to all of those kids we fit. Anytime we fit a new kid, or one that's maybe not taking care of the lenses the way they should, I'll give them an updated one and re-educate them on that. Okay, so if we're going to talk about fitting kids in myopia control lenses, then we need to talk about when do you initiate this, right? How do you know, oh, this is somebody I need to be putting in these type of optical corrections? And there's a whole list of risk factors for myopia development. And I think we all know what this list is, but what most of the recent research has shown us is that if the hyperopia, and this is such a funny way to say this, I always giggle to myself as I say that, if the hyperopia is less than expected for the age, that's when you get concerned, right? So we don't say anything about myopia in the statement. We say, hey, if they're not as hyperopic as we think they should be at a certain age, then they're likely to develop myopia. Whether it's tomorrow, next year, 2 years from now, I don't know. I can't predict that, but they're likely to develop myopia. And that's when the conversation starts, okay? And I would say that the conversation starts when that hyperopia is less than age expected, and the actual treatment, whatever that treatment may be, should be initiated when the cycloplegic spherical equivalent refraction is -50. So now we're myopic or greater. Okay. So the CLEAR study, I always call it the Cleary study. I think I'm the only person that calls it that, but I think I like that extra E on the end. So I like to call it the Cleary study. Really gave us evidence that showed that if a child is less hyperopic than 3/4 of a diopter, so if they're less than +75 in first grade, basically age 6, then that child is at an increased risk for myopia. Okay, so +75, age 6, that's like our baseline thing that we look at. If you have a 6-year-old sitting in your chair, if they're a +125, you can say, oh, hey, I don't think that they're likely to develop myopia. They could, I'm not saying they wouldn't, but they're less likely than if this 6-year-old sitting in your chair and they're plano or they're plus a quarter, right? So those people are going to be more likely to develop myopia. And so I always take it back to my kids. And so here we go. When my son was 6, he was plus a quarter and plus 50. When my daughter was 6, she was a plus a quarter and plano. So you look at that, and when my kids were 6, which those both occurred before 2015, but when they were 6, I should have been able to predict, they're likely both to be myopic, which I could have predicted anyway, because I have several of those other parental myopia, and some other factors that would make me think that. So if we extrapolate this out, if it's plus 75 at 6, the older they get, the lower that number is. So basically, you can go all the way up to age 11. So if someone is in your chair at age 11 and they are plano, they are still likely to develop myopia, and you still can start thinking about some sort of treatment for them. And you can see right here, 6 is plus 75, 7 to 8 is plus 50, 9 to 10 is plus a quarter, just kind of graduates down. So these are the numbers you can keep in the back of your mind when you're educating parents on the likelihood of developing myopia. And the nice thing about that is that we can delay the onset. So before we get to the phase of actually having to apply a contact lens to slow the progression, we can delay the onset through increased outdoor activity, decreased near activity, and some studies are showing maybe even using some low dose atropine can also delay the onset. And I think that we need a little more research on that, but there is some kind of early stuff that I've read that makes it promising to me. So if I have a kid that's between the ages of 6 to 8 and they happen to be more myopic than a plus 3/4, then I'm going to start educating that parent, right? So they're not myopic yet. So I'm going to talk about how we can delay that onset. And that's going to be with that outdoor play and that decreased near work, maybe doing low dose atropine and just putting the bug in the parent's ear. Now, if they're anywhere below the age of 11 and they have a myopic refractive error that's greater than minus 50, so we're now actually myopic in a least degree of minus 50, then I'm going to keep encouraging that outdoor play and, limiting that near work. And I'm going to start treatment. And I'm probably going to start treatment with contact lenses, because that's always my go-to is contact lenses. And if the parents won't do that, I know that's not what this lecture is about, but if the parents won't do that, I will also encourage low dose atropine as well. But I'm going to continue to monitor them for progression. So if when they're a minus 50, the parent says, no, I don't want to do it yet, I'm going to tell them, it's going to increase. I can tell you it's going to increase. I don't know how much it's going to increase. I don't know how fast it's going to increase, but we should do something. And when you see me next time, if that's in 6 months or a year, we're going to have the same conversation. I'm going to push these modalities again, because I think that educating is so important, because you need to get the parents on board. So when we think about our soft contact lens options to actually treat, so if they're actually myopic and we're thinking about our contact lens options to treat them, you have 2 options. You can do orthokeratology or you can do soft multifocals. And there's a whole bunch of options over here with the soft multifocals, but orthokeratology, there's a lot of different designs, I suppose, but I just kind of look at it as orthokeratology and then, all these different ways we could wear soft lenses. And the question I get asked a lot by parents is, which one should I do? Which one do you recommend more? Which one works better? Which one is your kid in? And luckily my kid's been in both. So I get to say, oh, well, you know what? My daughter has actually worn both. My son actually is not myopic yet, but my daughter has worn both. And, she had good success in both modalities, just different points in her life helped her choose different lenses she wanted to do. And then I say, it really has to be what works best in your life. Which are you going to be able to help your child put those lenses in every night? Or is your child going to be putting those lenses in every night? Or do you want them to wear them during the day? Do they do water activities? Do they play sports? I would probably push orthokeratology in those cases, because I just like the idea of not wearing contacts during the day. But the good news is there's now this retrospective analysis that just came out that takes and it applies real world clinical data to the research we know, and that found that it matches up. Okay. And what it's showing us is that the axial length elongation between orthokeratology and these peripheral defocus contact lenses is really not different. So you can tell the parent that whichever modality they choose should slow the progression of myopia for their child, and it will be effective. And it's not gonna like really matter which one they go with, right? You're gonna have success with both. And even though I've kind of been telling them for years, oh, I think it's about the same, we have some evidence now that supports that through actual retrospective analysis. And if you don't know the theory behind what these optical interventions do, it's basically this. It's basically if you took a pair of glasses, spherical glasses, or a soft spherical contact lens, a spherical GP lens, what happens is you've made that through your refraction to, line up perfectly with their fovea, right? And then that plane of refraction then extends up and down from that. And what happens is it's perfect here, right? They can see great, -2, perfect, great. But out here in the periphery, we've created hyperopic defocus, meaning the eye is too short out there in the periphery. And that is encouraging increased axial length elongation, all right? And myopia is a result of this axial length elongation. So if we can somehow take this plane and curve it to mimic the shape of the retina to where we change this hyperopic defocus to myopic defocus, right? So we're going to push it here in front of the retina theoretically. And then we can decrease that signaling and actually slow the progression of myopia. And that's what we're doing with these peripheral defocus soft multifocals and our orthokeratology lenses. They work in different ways, right? We're either building up the tissue on the cornea, or we're just doing it as an optical application with the contact lens. But that's what we're doing, is we're changing that shape back there, and that should decrease the signaling to increase the axial length elongation. And what we'll see is a slowing. It's not a stop. It's not a reversal. You can't reverse it. You can't stop it, but we can slow it down. And that's what the whole theory behind this is. Okay, so if you're fitting these contact lenses, what tools do I think you need? Well, I'm pretty minimalistic. Like if you ever listen to me talk about scleral lens fitting or specialty GP lens fittings, you give me a slit lamp, a topographer, a set of lenses. A slit lamp and a topographer, a set of lenses, and we're good to go. And the only thing I'm going to add on to that here is I do think that having some sort of A scan is helpful when we think about fitting these kids for myopia management. So I like to have an A scan because it tells you where you are. So you do want it baseline. And then really, I like the idea of every 6 months doing repeat A scans. So then you can monitor progression. So if that axial length is increasing, then you might think, okay, maybe I need to consider combination therapy or encourage additional time outdoors, something to like get this to stop increasing so much. But if you're monitoring it and it's not changing, right, you see less than 0.2 change, then you can feel like you are successfully controlling that axial length growth. So I really think that an A scan should not be a break, right? You shouldn't not do myopia management if you don't have an A scan, but if you have an A scan, I think you should use it. And then you have to have a topographer. And you have to have a topographer because you really need to do it baseline for whatever modality you're fitting them in. And then if you're fitting them in orthokeratology, it's so helpful to fit the lenses, to design your lenses, and then monitor success moving forward, lens position, troubleshooting, treatment, all of that is monitored with the topography. And I have a picture of a Medmont topographer here, but that just happens to be the one that I have in my clinic. I honestly don't care what type of topographer you have. Any topographer you have will work. Topographer connected to another machine will work. Like those combo machines, that's work. You can do progression analysis with those. You can look and check that position of that lens. Just using the topographer is the key. So get it with your baseline and then use it for your orthokeratology progression. You don't need to use it as you progress forward with your soft multifocals. So you manifest refraction. When we think about baseline data, cycloplegic's going to be best. If you can do a cycloplegic refraction to start with, that's going to be best. Clean slit lamp exam, that's going to help you a lot when you're considering disease and is the eye healthy for contact lenses. You want to make sure you want to get that corneal HVID. A lot of companies will ask that in designing the orthokeratology lenses. And if you're hands-on, you're not designing yourself, then you base the diameter off of the HVID. So having that is good. Pupil size measurement is important. That's going to help you with kind of thinking about success with both soft multifocals and orthokeratology. So I like to have the pupil size measurements and then baseline topography, A scan, and then always going through patient motivations and expectations is good. Okay, so let's jump into orthokeratology. And before I start talking about orthokeratology, I always feel like I have to say there are currently no FDA approved lenses for myopia management / myopia control in the US. Okay, no matter what advertising you hear, there are none. So anytime you use this for myopia management, you use it for myopia, yes, but for myopia management is truly an off-label to control the progression. But we have enough research to support using it. And so I think it's actually a safe off-label application, as long as you explain to your patients that it is off-label. Okay, so it's a reverse geometry lens. And what that means is you have a base curve, and if you think about a standard spherical GP lens, base curve, and then peripheral curves, and those peripheral curves get flatter as we go out. So you have base curve, flatter, 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 however many peripheral curves you have. Reverse geometry simply means we're doing the reverse of that. So you have your base curve, and that first peripheral curve, instead of being flatter, is steeper. Okay, and it's steeper because what that does is it actually allows the lens to center better on the eye, and you can create sagittal depth bulk to actually apply pressure to that central cornea to push the tissue out to correct for the myopia. And then your remaining peripheral curves is what ends up making your alignment zone, and those are going to become very flat. So you're going to go steeper, then very flat, so that you can line out there. And a very well fit orthokeratology lens, it doesn't land here, right? You're not landing here, you're landing here, out here in your alignment zone. So this is where most people call this the return zone. So this is where we're applying our pressure. Here's our this is your base curve, and then here's your return zone. So this is where the tissue is getting built up. So we're pushing it out, circumly here, it's building up here, and then out here in your alignment zone is really where your lens is landing. So if you were to ever look at like epithelial pressure pictures under an orthokeratology lens, you absolutely have more pressure here, and you should have more pressure here than you do here, because your lens, to center well and to treat well, really needs to be landing out here. So we get this mid-peripheral steepening. That's what's going to change our hyperopic defocus to myopic defocus in the retina, so that we can slow the progression of myopia. So that's all what's occurring here in this mid-periphery. And this is just showing you how that lens may align here. What we have is, there's CRT, VST, both FDA approved, just, however the company decides to label their lens. And they're both approved for minor all the way up to moderate to higher myopia, right up to 5 or 6 diopters of myopia. And honestly, I think you can be very successful 6 diopters of myopia, 7 maybe. Higher than that gets a little suspect. But I find if you really want to stick to what's going to be most successful with orthokeratology, up to about 4 diopters of myopia. I like to keep it around 175, maybe 2 diopters with the rule is going to be more successful. About half that for against the rule. I have about a diopter there, 3/4 to a diopter against the rule. And then, when you go above that, you're going to be less successful. It's probably going to be a little bit more difficult for those higher myopes, higher amounts of astigmatism. Now, the good news is we have advancements like we do in all lenses, and we have toric designs for orthokeratology lenses. And whether you design these yourself or if you use topography or computer-based, we have toric designs that allow these patients that have higher amounts of astigmatism or a cornea that has different sagittal depths. This allows the lens to sit down on it more evenly. You're going to get a better treatment, a better visual outcome, better comfort for the patient, less decentering of the lens. So I think that nowadays, I feel like I see about toric designs about half the time I order them, and spherical about the other half. So you're seeing more and more of these toric designs because they just tend to be a little bit more successful for our patients. when I think about this in terms of myopia management, I personally think that your ideal candidates for orthokeratology start at about a diopter and a quarter and then go up higher than that. I have 4 on here, but if you want to fit 5 or 6, we can do that. And the reason I say that is the theory behind this is all based on that buildup of tissue in that mid periphery. If we don't have enough myopia to push out there to build up the tissue, then we're not changing that hyperopic defocus to myopic defocus. So you have to have a amount of myopia that will actually create a change in how that light is hitting the peripheral part of the retina. So I would say 1 1/4 is about as low as you could go. If you have a kid that is, say, a -75 and you want to put them in contact lenses for myopia management, I'm going to encourage that child to go into a soft multifocal, because I personally do not feel I would get enough treatment out of an orthokeratology to make it as effective as I could with a soft multifocal with a high add power right off the bat. And that's my personal opinion. I know there is some research out there and some studies talking about adjusting the Jessen factor, pushing it more into the plus, so you get a larger buildup. That is not the way I practice personally at this point, and I need to see more evidence moving forward before I change my practice to start incorporating that change into my lenses. So right now, 125 is about my bottom mark. And if it's less than that, I'm going to personally pick a soft multifocal. If it's higher than that, I think you can go great with an orthokeratology. You're also looking at kids with larger pupils. And the reason you're looking at kids at larger pupils, if you can see here, this is a patient of mine that was fit in orthokeratology, and here's their treatment zone. So this is their topography, here's their treatment zone, and then all the red areas, the buildup of tissue. So the black here is their pupil. So you can see here, my buildup of tissue is within that pupillary border. So when that light comes through, it has to go through the pupil. So if we want the light to be mimicking the corneal shape, that corneal has to change shape within the pupil, right? So you can see here, black circle is pupil, dark area below is pupil, this line is this line. So the buildup of tissue is actually within the pupil. So when you look at this on topography, you can say to yourself, aha, my buildup of tissue is within that pupil border. This should be doing what I want it to be doing on the back of the eye to my retina, the light. I should be doing everything appropriately to actually get this, this slowing down of progression. So this is really what you want. You don't want one of those big, beautiful treatments that like we wanted to with our adults. You really want something that mimics like that. And what we have to help us with this is some newer myopia control designs. And there's actually some recent studies and data that has come out that have shown that you can actually be a little bit more successful when you utilize one of these designs that has a small optic zone diameter. So you can see here from this article that this is a picture of an orthokeratology lens with a smaller optic zone diameter that you should think about using for myopia management, or you can manipulate the parameters of yours to get this, versus if you were doing an adult design that we're not trying to do myopia management on, then you would go with this larger optic zone diameter. So you can actually trend down to smaller. So this is a 5.4 versus a 6.8. And here's just the kind of a study that talked about how this is more successful in a year-long study, but that we need more data to truly see the impact on that. And the study needs to include some, pupillary diameter studying as well. So it's an area of research that can keep going. Okay, so how do you fit orthokeratology? Here's the good news. It's so easy nowadays, right? K values from topography, get your A scan, get your HVID, send in that manifest cycloplegic refraction, tell them the pupillary design, call up your company. Maybe you send them the pictures from topography if they want it, and they're going to design it and send you lenses. And these lenses tend to work really, really well. If you want to be more hands and go diagnostic, I have fit tons of lenses diagnostically in my career. And the main one I happen to have used was a CRT. CRT also has a toric design now. This is great. If you feel like you can put a patient in a lens and you don't need a toric design, meaning you feel like their astigmatism is low enough and that the sagittal height difference at, say, an 8 or 9 millimeter cord is less than 30 microns difference, then you say they will do fine in a spherical lens and you have a CRT lens set. I think you can be very successful by picking your lens that way. If you feel like you might need a toric lens because they have a sagittal height difference that's greater than 30 microns or a large amount of astigmatism, then you can feel very comfortable feeling that a topography-based or a software-based lens design will meet your needs and be very easy to order and then fit on the patient. So there's lots of options here. And I really am not a proponent for one type of lens over the other. We use multiple in my practice. I use multiple. I like to change it up with each patient. And I think they all work really well. And what I think is when you're first starting out, if you can pick one design, one company, go all in with it, then you'll get very good at troubleshooting it, knowing how the lens is going to work, knowing what to expect, and you'll be more successful, and then kind of branch out if you want to go out beyond that. And that's kind of my theory for every lens that I fit in my practice. If you don't know much about what the base curve should be, and you want to double check if the lab did it right when you're doing your topography or laboratory based, is really your base curve should be the amount of myopia. So if they're a -2 diopter, it should be that amount flatter than their flat K. So let's say they're a 42 is their flat K, 42 diopter, and they're a -2. Then I would expect the base curve of my lens to be a 40, right, for the 2 diopter minus, plus a Jessen factor. And just so you know, what the Jessen factor is the amount of power we add to the lens that overcorrects them so that when they wake up in the morning, instead of being plano and they take that lens off, they'll hopefully be that amount more. So when you get these lenses, they're all plus power. They're like plus 50 or plus 75. That's the Jessen factor, right? So that's the little bit of power that's been added into the lens. So then they wake up and take them off, they're a plus 50, so that maybe when they go to bed that night, they're plano or -1/4, because you're going to slowly lose your power during the day. So that's why these lenses are all low pluses. So in my example I gave you, if the Jessen factor was a 50, then I would expect my base curve of my lens to be about a 39-50 diopter lens. So if you ever want to check that, that's what you can do. I tend to always prescribe hydrogen peroxide solutions. I think that they work really well with orthokeratology lenses, and the kids have no trouble using them at all. I think it's helpful to change the color of the lenses too. I like red for the right eye and blue for the left eye. You can also do green for the right eye, yellow for the left eye, something where I can tell the patient and the kid, hey, red R, right, blue L, left, right? So that's kind of how I talk to them. And then for your follow-up schedule on these, you can do one day. I know it's been very traditional in the world of orthokeratology to fit the kid, teach them INR, have them sleep in the lenses, come back and see you the next morning. Well, here's a big tip that I have learned, and that is I don't see my kids at one day. I stopped seeing my kids at one day probably about 10 years ago. And the reason I stopped doing that, I now see them all at 1 week. And the reason I stopped doing that was because I spent a significant amount of time in the exam room on day one, answering questions and making everybody feel better about the process of orthokeratology, that I found if I made them wait a week to come see me, they had figured out all on their own. And then I didn't have to answer these questions that I had just told them about the day before, that I had already answered the day before. I didn't have to re-answer them because, man, they had a really bad first night, right? All that kind of like gets lost in the memory because they come in a week later, they're seeing really well. They've really nailed the insertion and removal. They're doing pretty well with the lenses at that point. They ask you the questions that are really important. We're having this issue, and then I can answer those questions. So the appointment becomes actually more impactful for both of us, and we've got some really good visual data, right? I am not going to change that lens at day one. It would have to be an egregious fit for me to change that lens at day one. I am very much a wait and see type of contact lens fitter. I'm much more likely to change it at week 3 than I am even at week 1. So that whole day one appointment I found was just really not impactful for me or my patients. So I've started seeing them at 1 week, and it has been a really good change to how I see my patients, and I haven't had any negative issues from it yet, which is good. Then after that 1 week, I typically see them at 2 weeks after that, a month after that, and hopefully everything's finalized at that point and we can go to 6-month follow-ups. At those follow-up appointments, you need to do a topography every time. You need to do a refraction with those lenses on the eye and with the lenses not on the eye, so you know where you are and you can make sure that the lenses are still appropriately fitting. Your refraction with the lenses on the eye should be similar or the same as your Jessen factor. So it should be very low plus a 75, plus 50. You want to take them off, do a corneal evaluation. You may see some staining very early on. That should not be something you see late. Like you should not see that at 1 month. You should not see that at 2 months. If you do, you need to check to make sure the lenses are clean, make sure there's not something else going on, because you really shouldn't see any staining at that point. I always do a fit evaluation, and then we do an A scan at every 6 months. So what are some different fun scenarios to consider? I always think when you think about follow-ups, you think, when is this lens not working as well as I want it to? So if I saw a kid at 8 a.m. in the morning and their refraction was a low plus, you know what? I'd be like, okay, today's going to be a good day, right? Kid number 1, ortho-K, plus 50, 8 a.m. Nailed it. This is going great, right? I'm not going to touch that lens. Everything, in my opinion, is going fine visual-wise for that patient. Okay. Now it's noon. So now it's noon. I'm seeing the kid. The kid has plano refraction. Now these are refractions without lenses on the eyes. The refraction's plano. Okay. Once again, I'm pretty okay with plano at noon, right? We've made it half the day. They're at plano. They see well. I'm not going to do anything with that lens. Now we're moving on, and we're 3 p.m. in the afternoon. Okay, 3 p.m. in the afternoon, no lenses on the eye, refraction is a minus 50. Okay, so let's see, I don't know what time the kid got up, but maybe they haven't had their lenses on for 10, hours at this point. It's been a long day. Maybe it's only 8 hours, minus 50. I'm going to be cautiously optimistic that everything's going okay with the lenses. I'm going to ask them about the possibility. Do you seem to have a lot of blur at night? If they say no, I'm going to continue being cautiously optimistic and probably bring them back for a follow-up appointment in the morning so I can kind of see what's happening when they first get up. And I'm just going to probably bring them back in a couple of weeks and do that and not change anything at that point. But now let's go back to noon, and let's say that one of those kids' refraction at noon was a minus 1. That's not good. This is someone that if they're a minus 1 at noon, they probably weren't a low plus first thing in the morning, and they're probably like a 150 or 2 at night. And we all know that you really are not going to be able to see very well with that. So at that point, I really am going to look at the position, the fit, the treatment, and I'm probably going to modify those lens parameters to improve the vision, because they're probably not getting enough treatment for that. And like I said, that over-refraction should be a low plus. It should mimic the power of your lens. Okay, so on your post lens wear, this is going to be your treatment zone. Here's your mid-peripheral steepening is going to occur right out here. And then your alignment curve is out here. So you can see how this is a much darker blue. So this is where our lens is actually landing on this eye. And then just real quickly, I want to show you, when you look at these topographies, it's really important for you to be able to get the data you want to get to understand what you're looking at. So this looks like the world's best ortho-K treatment ever, right? It's beautiful. It's big. It looks great if they were an adult. This is not a sensitive map, right? I've got 2 powers dioptic change, right? So I'm treating 2 diopters of myope, and I'm looking at a differential standoff of minus 10. I'm sorry, this map is truly not telling me anything about the fit of this lens. If these 2 are not matched up, you don't even know what you're truly looking at. So you need to go into your program and you need to set these to where they actually mimic each other so you can truly see what's happening. And this is going to help you if you're doing troubleshooting on these lenses. So here's that minus 10, not sensitive at all. As I decrease these powers, you can see here where the 2 and the 2 are matched up, you can truly see position, treatment, everything in that subtractive map. So go in, adjust that on your topographer, and you'll do better. And the other thing I always like to point out to people is all 3 of these are really good orthokeratology fits, even though half of you are out there looking at this saying, that's an awful fit, Dr. DeKinder. What are you talking about? Guess what? That's actually a really good fit. You don't know what the power or what that person's refraction is. If this person is only a minus 150, that's what you expect the orthokeratology to look like. You're not pushing much tissue here. If they're a minus 4, yeah, it's probably going to look like this. But if they're a lower myope, this is going to look good. And this is a good ortho-K fit. You do not need to manipulate these lens parameters if they're based on the patient's refraction, K value, HVID, and topography. This is likely the correct lens. And don't go thinking just because this isn't the textbook image that you need to change anything, because you probably don't. Wait until you have visual data and then decide if you need to change something on that. Monitoring for ongoing success, 6 months. right? So you want to do a 6-month follow-up, or you can do 1-year follow-ups. If your refraction is greater than half a diopter, you might need to change lens parameters, or if you're seeing more than 0.2 elongation. So that's when you might change it. If it's not like that, or if it's only half a diopter, it might be, these are higher oxygen lenses. The lens may have changed a little bit in shape, and you might need to just adjust and order them a fresh pair. And it might take care of that small amount of myopia there. Okay, let's transition to soft multifocals. Once again, all soft multifocals are off-label, except one. In 2019, MySight did receive FDA approval. So if you want on-label for these peripheral defocus soft lenses, MySight your lens. If not, then you need to remember that all the other ones are going to be off-label. Multifocal lenses, this is a very straightforward process with fitting them. You have to select a multifocal lens that has a center distance design, right? So you're going to go only with the center distance designs. And then you want to put the add power, that's the highest add power that is acceptable to the child without compromising their distance vision, okay? Highest add power acceptable to the child without compromising their distance vision. Big options here, Biofinity or ProClear multifocal. Those also have a toric option. D-lens both eyes. D-lens both eyes. Natural View and MySight are your daily disposable options. This is our on-label one. And then if you really have a kid that's got a pretty a refraction that's kind of outside normals, high amount of astigmatism, and you need a very, very specialty lens, you can go with this quarterly replacement option through Specialized, which is their 54 bifocal multifocal, which is also a center distance lens. So the key there is going with the center distance lens. So your initial lens selection is going to be based on that cycloplegic refraction. So you can take that center distance design and throw on that highest add power you can. So here's an example. If I had a -2 myope, my initial lens selection theoretically should be putting a lens on them that's a -2 for their refraction, and then say a +250 add in a D lens. Okay, if you did MySight, you would just pick the -2 lens. MySight has a standard +2 add. Okay, so it's just +2. If you go with like the Biofinity or the 54 bifocal, you can go up to these higher adds. So you can do the +250 add would be what literature shows us. And what the Blink study showed us is that, yes, the higher add slows myopia more effectively than the lower add. So if you can get a child to see well with a 250, it's better to use that 250 than to use a 150, okay? But I would also argue, if you have a kid in a 250 and they can't see, then you're probably defeating the purpose, because the kid can't see. And then you need to look at other alternatives. And we're going to talk about what those might be, because 250 is a lot of plus to get there. So what happens if this child cannot see with +250? Well, I started doing this, and this actually tends to be pretty effective. And that's, I do a buildup. So if I put that -2 +250 on them in office, and it's like 20/40, and it's just not good, then what I'm going to do is I'm going to grab some trial lenses. And I'm going to say, okay, here's a -2 with a +150 add. And I'm just using this example in a monthly lens modality. Here's a -2 with a +150 add. You're going to wear this, check their vision. It's usually at that point you can get them to 20/20. I want you to wear this lens for a month. And then I give them a second set of lenses. They're a -2 with a +2 add. And then I give them a third set of lenses that are a -2 with a +250 add. And I say, you're going to go away for 3 months. And you're going to wear the +150 adds for a month. And then when you're done with that month, you're going to switch to the +2 adds. And then when you're done with that month, you're going to try those +250s. And that's when I want to see you back. And what that does is it actually allows the child to gradually get used to that increased plus, and their vision with that 250 ends up being a lot better. Now, does it always work that they can adapt to the 250? No. Absolutely not. It does not. A lot of times I have to keep these children at the +2. It actually just happened yesterday. I saw a kid, the previous practitioner had put him in the 250. Kid was not seeing well. I said, let's go try some 2s. Kid saw 20/20, walked out the door. We ordered the lenses. So sometimes that 250 is just too much, because what happens is it actually kind of gets in closer when you're using this, when you're not using the MySight, which is the concentric design, that gets in closer. So you're losing the amount of distance they have. And that's why it's kind of degrading their distance vision. So that's kind of my step up approach to that. The other thing you can feel pretty comfortable about is if you have someone in the 2 or the 250 ad and they're still not seeing the way you want them to, and you find a pretty small overrefraction of say -50, -1/4, -50, you can safely incorporate that into the lens power, effectively over minusing the kid, and it will not adversely affect the progression of their myopia. Okay. I was petrified of doing this for years before the Blink study came out with this data. I would be like, oh, I'm getting all these these low over refractions, and I do not want to over minus these kids. It turns out you can do that. You're not going to adversely affect their myopic progression. Okay. So if you have them in the 250 ad, and you have to add -50 over refraction in, do it and feel comfortable doing it. It's going to be okay. It's still going to be very effective. So you're going to do that cycloplegic refraction with that highest ad power, and then adjust your over refraction for improved visual acuity with these soft contact lenses. And really, you want to encourage the kids to wear these lenses for at least 8 hours a day, right? You really want full-time wear, but at least 8 hours a day is going to allow you to get that myopia management. And just remember, the MySight is concentric rings, and it's +2. So even if you're fitting a lens that's not on label FDA and you only can get the patient to +2, feel comfortable with that, feel confident, you'll be perfectly fine with that. So here's an example of a patient of mine, 11-year-old female, low myope. Put her in some Biofinity D lenses. This is before MySight was on the market. Put her in a -1, +2, and a 75. She was 25 minus, got a small over refraction, incorporated the over refraction. She wore those for a month. I then had her wear the 250s for the month, came back, could see 20/20 out of them. We went with it. That's what we finalized for the next year. Came back 1 year later, basically same prescription, kept her in the same lenses, and continued with the same for the next year moving forward. So it's pretty straightforward. The soft multifocals are pretty straightforward as long as you stick with that center distance and think about pushing the plus as much as you can on that ad. I think you're going to be pretty successful with those. If you are following these soft multifocal patients, every 6 months is when I like to see them, especially since they're kids. And if you're seeing more than half a diopter progression, you may consider trying to increase the ad power if you need to do that, or add in some sort of combination treatment if you feel like the soft multifocal isn't getting the treatment you want. So just really quick scenarios. I think I'm running out of time here, but these are my actual patients that I saw, and then you have to decide what are you going to do with them. So 7-year-old female, -4, right eye -450, left eye, what do you do? I started myopia management immediately. So this is probably a kind of a pathological myopic condition or a situation where we don't truly have research to support it, but anything you can do is going to be helpful. And I would probably in that case also add combination atropine. 6-year-old male, -225. Yep. This kid just came into my office a couple months ago. Educated them all about orthokeratology. She said, nope. She had an 8-year-old. She said, fit him, not him. And I said, okay, we really need to fit him. Came back a week later and said, change my mind. Go ahead and fit him. So they began orthokeratology after I educated the mom on the importance of really getting the 6-year-old fit in addition to the 8-year-old. 10-year-old male, plano with a little bit of astigmatism. You know what? Let's try to delay the true onset of myopia here. So monitor them with 6 months, outdoor play, decreased near activity, and low dose atropine if you feel comfortable and they feel comfortable on that. High myope 15-year-old. Gosh, this is probably too late for any significant, but you know what? Anything's better than nothing. And if they're willing to try it, go for it. I'm currently refitting a 21-year-old that's a -9 out of one modality into another one. And she wants to keep going because she is concerned about increased progression into adulthood. And I think that is something that we're seeing. And the last thing I'll hit on is, hey, doc, when can I take my kids out of these? I don't know. I used to tell people 16 way back in the day, and now I don't say anything until they ask me when you can take them out. So, I mean, does myopia truly stabilize around 14 to 16? I don't think so. I think we're seeing that it's increasing into the 20s. And as long as the child sees well out of it, they're comfortable in the modality they're in, and they don't have the desire to change, I say keep them in it as long as they're willing to stay in it. If one of those things isn't happening, then feel free to take them out sooner. But I think if you can keep them into the 20s, you're going to be more successful. So, you know what, I think it's easy to educate parents. It's easy to incorporate into your practice. It could be a huge practice builder. And I'm just thrilled that I could talk tonight. And I hope that I've encouraged some of you to jump into this.